Okay guys, what we're going to do right now is just go over a bit of the equipment that you're going to require for airway management. First and foremost, I think it's imperative that if you are the one doing the intubation, it's your responsibility to actually check your equipment. Assemble it, check it, and be sure of the operation so that when you are actually doing your intubation, you know if anything is working properly or not. The setup of equipment is going to be, first off, collecting everything that's going to be required. So you can always do this while your patient is pre-oxygenating if it's not an emergency situation, or even prior to if the patient has arrived, if you know preemptively that you're going to do some intubation. First thing you're going to get for yourself is a resuscitation bag. And I always do a quick check on my bag to make sure that it's actually holding pressure. I include the end, push on it to see if the pop-off goes off, close the pop-off, I want to squeeze to make sure it's holding any kind of pressure. And we can even do a negative pressure check on this, but I'll show you that in lab if necessary. Next thing I'm going to do is look at my actual instrumentation for laryngoscopy. So you're going to need a handle with operating batteries, a blade that actually fits the handle. So I'm using a standard handle, standard blade here. This is a Mach 3. I'm going to actually make sure the bulb is nice and tight on the distal tip. Flip it on and check that the light is actually working, okay, and that it's bright to your satisfaction. I have a number 4 blade if I was unsure of the insertion depth, so I can also check that. Look at the bulb, tighten it, make sure that it's working appropriately. I'm going to leave the number 3 blade on as that's the most common one. I'm going to leave it in the disengaged position. Next thing I'm going to do is check my endotracheal tubes here. So I've got a number 7.5 and a number 8 for my adult male patient here. So I'm going to prepare both of these. What I'll do is I'll get a cuff inflator, and while it's in the package, generally what I do to kind of keep it clean is I'm going to insert a couple cc's, probably 10 cc's or so of air into the cuff and make sure that it's holding pressure. So insert, and then basically I just squeeze on the cuff to ensure that it's actually holding. And you want to deflate all that air all the way back out so that when you are using that tube, it's not going to cause any kind of obstruction of your view or have difficulty going through the cords itself. So I would do that with both tubes. Next thing I would do is look at getting a stylet. Stylets are great to assist for any kind of intubation attempt, especially if you don't know if the larynx is anterior or not. Lubrication is going to be a good idea to just slightly lube up the stylet. You can use some gauze. And very briefly, or very slightly, you can lube up the distal tip of the endotracheal tube as well. Thinking ahead to basic airway management, I might get some Goodell airways ready so that my bag mask ventilation will be more effective and I can always achieve oxygenation and ventilation. I've got here an end-tidal CO2 clip that's going to go on the end of my endotracheal tube once I've performed my intubation, hopefully detecting the presence of carbon dioxide, indicating that I am in the trachea. I'm going to get some securing tapes ready, and we'll go through how we secure an ET tube. And finally, I want something that may be used if my intubation attempt fails. It's always a good idea. I always have an LMA on hand, or at least in quick reach, so that I know where this is. If my intubation is going poorly, I can have something to reference quickly. You may also want to grab a number of different masks if you don't know the size of your patient that may be adequate for bag mask ventilation. And you want to prepare your PPE as well. CRTO guidelines say that for any intubation attempts we're going to be using gloves, mask, and eye protection, so goggles. You're going to do your own risk assessment as well to identify any other hazards that you may want to take extra precautions against. Okay, so now we've checked our equipment. The next thing we're going to do is move on to our patient and preparing our patient for an intubation. First and foremost, verify that we have proper oxygenation. So if your patient is spontaneously breathing, a non-rebreather, so close to 100% oxygen, as close as we can get on a flow meter that's 15 liters per minute or flush, is adequate. If they're not spontaneously breathing, that's where you or your assistant is going to have to manually ventilate them for a minimum of 8 to 10 vital capacity breaths with your manual resuscitator. Possibly even looking at your saturation until you've optimized the situation. It's very important that you can establish nitrogen washout and pre-oxygenation prior to an attempt. Positioning your patient, you're going to want to put them into that sniffer's position, so extend the neck a little bit, do the chin lift. If required, you can use an assisted roll to help get your patient into that alignment so the pharyngeal and laryngeal planes align. And lastly, you want to look at your operation of intravenous and your monitors. So it's very important that we have a working intravenous so that we can give our pharmaceutical agents that are going to help us with our induction and possible paralytics for intubation ease. ATS criteria says at minimum we want 3-lead ECG, non-invasive blood pressure, and a saturation probe that you can see we've got on our monitor here. Once you've prepared all of your equipment, you've prepared your patient, and you're satisfied with the operation of your intravenous and your monitors, at this time it's appropriate to prepare everybody else that's going to be your assistant for the intubation attempt. It's usually a physician, a nurse, and a respiratory therapist, and the roles will be delegated or assigned prior to, and be very informed of what your role is and what you're going to do as either the intubator or as the assistant.